a topic that brings together two important and often interlinked conditions, cataract and chronic dacryocystitis. It is my pleasure to welcome Associate Professor Dr. Ranjana Sharma ma'am, who is the current Vice President of NOS and a renowned oculoplastic and reconstructive surgeon. She will be surgery in chronic dacryocystitis, its challenges and considerations.
First of all, I would like to thank Dr. for organizing this CME and giving me a platform to talk. Respected President and immediate President of Nepal Ophthalmic Society, respected all panelists, my dear colleagues, all the speakers, very good afternoon. Before starting this topic, I'd like to ask to all cataract surgeons, how many of you check for this patency of NLT before doing cataract surgery? Please raise your hand. I'm talking in front of a very surgeons working in a very high volume. Yes, I'm happy. Most of you check for this patency of NLT. Yes. So my presentation is a little bit different. So I'll be talking on cataract surgery in chronic dacryocystitis. We all know what is chronic dacryocystitis, but we have to know this patient can present with epipora. If epipora is very easy to diagnose, sometimes only with the discharge, very rarely with the pain and redness, and sometimes only with the chronic conjunctivitis. So in that case, we may miss the case of the dacryocystitis. So before going to this, what is the normal flora we have in Nepalese population? Dr. Purnima Raj studied and she has studied all the normal flora, and coagulase negative staphylococcus was the most common. So before this, I would like to thank Dr. Sanjay Singh when he was the president in 2015, and this protocol was made 10 years back, and still we are following the same protocol. And Nepal Ophthalmic Society, with support from IAPB and apex body of Eye Health, Ministry of Health and Population, Government of Nepal, they made this cataract surgery protocol. And all high hospitals representative perform more than 20,000 cataract surgeries per year were invited. Now the scenario is different. That time, that protocol, if you have seen, the syringing has kept as optional. And this 2015 cataract surgery protocol for Nepal, developed by Nepal Ophthalmic Society and endorsed by Ministry of Health under IAPB guidance, remains the basic national standard for all Nepalese eye hospitals, even today. But it is sufficient in today's world in 2025, especially in the setup where we have all private setup and medical colleges, where we have around 350,000 cataract surgeries annually being done. What I say, yes, it's still relevant, but it is not sufficient. It has to be revised because there is new techniques, because most of you do the clear corneal incision, and we say that conjunctiva is the one which harbors microorganisms. And there are modern IOLs who have very low infective rate, updated antibiotics and follow-up protocols. For the evidence-based auditing, it is very important. Recently, there is a consumer court is active, and we must have the evidence and protocol for the management. And also sector-specific, like nowadays there are so many other centers like tertiary centers, outreach clinics, private hospitals, and even medical colleges where the cataract surgery is being done. So we need to revise this protocol. So while making this presentation, I searched the literature. I found in India there was a survey, nationwide survey, conducted by the Indian ophthalmologists among the Oculoplastic Association, members of Oculoplastic Association of India. It was a questionnaire survey, and what they found was 92% of the respondents, they checked for the patency of the drug, and 59.6% do only reproblast test, and 32.6% do the syringing. And 84% performed TCR before cataract surgery, and the 4 weeks interval was given for the waiting period. And 60% of them use the intercameral antibiotics. So what they suggested, like screening for cataract, for all cataract surgery, this NLT obstruction has to be screened, and inquiry about the epipora has to be done, because if there is epipora, there is high chance of infection. If chronic dacryocystitis, we have to do the surgical management and wait for at least 6 weeks for the normal flora to appear. So in some condition, we have to do the medical optimization also, because if the patient cannot undergo DCR surgery, in that case we can do syringing, culture, and use the antibiotics. A delay for surgery 6 weeks they have advised, and while doing the surgery we all do this COVID and iodine cleaning and also post-operative antibiotics according to WHO standard. So DCR, what is the success rate? Being an oculoplastic surgeon, I have to talk about the success rate of DCR. But reporter and et al, they have studied this in Nepal, external DCR at 88.6. And still we do external DCR, but the scenario is changing among the oculoplastic surgeons these days. Most of the oculoplastic surgeons, they do endoscopic DCR. And in China, there was a study to assess the safety and optical timing for intraocular surgery after endoscopic DCR. And it was a retrospective study, though the sample size very low. And they have intraocular surgery, they have mentioned was the cataract, glaucoma, and retinal surgeries. And they have taken the time interval. Most of the cataract surgery were done within 8 weeks. And even the retinal surgery was done within 8 weeks. So the surgery within 8 weeks post DCR was safe. And but there was a wide range from 5 to 475 days between the endoscopic DCR and intraocular surgery, and no endophthalmitis was noted over 1 year. So timing of intraocular surgery should be guided by the absence of discharge and lacrimal patency, not fixed by the duration, what they have concluded. Because this study, what I am quoting here, it has the limited data, retrospective, and no comparison with the patient who had undergone endoscopic DCR. So when does this normal flora comes back to normal after DCR? This is also very important to define the duration, how much we have to wait. There are different studies. Most of these studies, they have waited up to 8 weeks. They say that in 8 weeks, most of the flora becomes normal. But in last one study, even after 1 year, still the conjunctival flora is altered in compared to the other eye. So conclusion of these studies, they have said that never proceed with the cataract surgery in presence of untreated dacryocystitis or NLGO. Perform external DCR within 6 weeks, confirm patency of NLG, apply usual cataract aseptic protocols, and use of antibiotic based on local bacterial data for best prophylaxis and outcome. So what we do here, being a medical institute, being a department, what we follow protocol in our center is we screen it, because academic center we screen for irrespective of the watering or before or discharge, we screen for all the patient for us this NLG obstruction. If positive, we do DCR, external DCR mostly, and then we wait for around 6 weeks, and we follow all this standard cataract surgery protocol, intercameral moxie, and we give a subconjunctival antibiotic depending upon whether the block was given or not. And close monitoring is done up to 1 month. So to conclude my presentation, there is a strong consensus that everybody says that in NLGO obstruction, we shouldn't do cataract surgery, but it depends upon the surgeon and center. In Nepal, if the single surgeon, he follows this protocol, if he is working in the medical institute or any tertiary center, but in the private clinic, there is a question mark. No uniform guideline exists for the optimal interval between the DCR and cataract surgery. Now it's very high time to revise, because we don't have proper data of endophthalmitis. What is the proper data of endophthalmitis rate in our country? While making this presentation, I reviewed some articles. In 2010, there was a reporting from Lumini Eye Institute about the huge endophthalmitis, huge number of cases with the endophthalmitis. And recently in 2021, there was a publication from Cheers Hospital about the management of endophthalmitis cases. But nowhere I could find the rate of endophthalmitis and the reporting of endophthalmitis in our country. So now is the high time, and the consumer code is active, and we have to follow the protocol. There are so many emerging hospitals, new surgeons, techniques. I think it's very high time to revise this protocol, and survey is needed, nationwide survey is also needed. And while making this presentation, I came to realize that it's a time to do our one survey. So with the due permission from our President, Nepal Ophthalmic Society, I'd like to carry on this project after this CME is over. And if anybody wants to join with me, please mail in this address. Thank you.